Welcome, everyone. I'm glad I can be here today. Again, my name's Jim Chase. I'm president with Minnesota Community Measurement. And I was struck recently by an article in the New England Journal of Medicine that cites the low rates of aspirin use in the U.S. for the secondary prevention of cardiovascular disease. And in this article, despite the strong evidence of efficacy for that population, it said in 2007 they had looked at this, and the national rate for prescribing antiplatelet medication for people with ischemic vascular disease was 47%. Now this isn't about people actually taking the aspirin, this is just prescribing it for those that need that. And the article went on to bemoan that, and something needs to be done and so forth. And the reason why I was struck with that is in Minnesota, we've been measuring and reporting aspirin use on much the same population as they measured for patients for the last 8 years through our optimal vascular care measure. And the statewide average for aspirin use in that population has been steadily growing over time, and this last year was 95%. So I hope you're stunned by that. 47% nationally, 95%. Now I know others of you are stunned that I actually read an article in the New England Journal of Medicine. Now, I actually don't read it regularly. Many of you know I get most of my health news from watching Wait, Don't Tell Me on the weekend, but or listening to it. But Gail Amundsen actually sent it to me, so it called it to my attention. I have to give her credit for that. But again, this wasn't cherry picking. This is on 200,000 patients across the state that are in treatment across all practice settings, both in safety nets, in specialty care practices, in rural settings. And we see this higher level of achievement across many of our measures, from blood pressure control to optimal diabetes care to cancer screening. And if you talk to local clinicians about how we've gotten there, they'll say it's because we have a culture around measurement and improvement, trying to use measurement and transparency to increase the results. And we've been redesigning care to actually try to achieve that, and much through the work that you hear later around ICSI in our community. And also that there's a recognition that it takes multiple stakeholders around the table to really have an impact on the triple aim. And that's the essence of what you've heard that regional collaboratives do. And so what you'll be hearing much more about today, and I just wanted to give that as an example of some of the things that are going on. For our time here today, I would like to give you just a little bit of background about community measurement. We've been around for about 8 years again, working around using measures to improve the care in our community. And we now have grown quite rapidly. We came together when health plans and providers who were working on improvement realized they needed more data. They couldn't have it sort of one-off with everybody doing something different, so we agreed to come together as a multi-stakeholder group and provide the information. But we've now grown to having over 18 clinical quality measures in physician practices, health information technology, patient experience, cost of care, and hospital measures. The other thing that's very important that we can do as a collaborative is get everybody to participate. We now have just about every provider in the state working with us, 315 medical groups and 672 sites of care. And we've been able to, because of our trusted source, get information both from health plans but also clinical data from practices and data from hospitals. And now, even more importantly, using patient-derived data, which we often get through the practices, but not just data out of medical records, but also information from the patients themselves. And this is what drives much of what gets us traction here. This is just our data from colorectal cancer screening. Again, we have higher rates than average in our state than compared to across the country, but it's an area where we still are about 65%, as you'll see in a moment, of people being appropriately screened. And there's a great opportunity to be able to do more. But what drives the difference isn't just knowing that there's a gap, but when you can see this is the practices laid out across the state, that you have some that are very low and some that are high, and probably it isn't so much those outliers, but when people see the folks down the street with very much the same population that they have doing better than they are doing, it drives improvement. Or sometimes I hear, it's the guy down the street who I went to medical school with, who was my friend, and why can't I do as well as he's doing? So this has been an important driver of our work, but also the fact that we've been able to see change and improvement. So here's our colorectal screening rates over time, and we've seen 1% and 2% changes over the years per year. And you think, that's not very much. But again, this is on 1 million people who qualify for this measure in our region. So that's every percentage point that we can change is 10,000 people more screened this year appropriately than were in previous years. And that means hundreds of people who are going to avoid the complications and problems of this condition. So I want to just jump to why it works for us as a multi-stakeholder collaborative. It's been very important, what we found, to be a trusted source of information. And that's hard to do if you're just the health insurance company or just provider organizations. We need to be able to do it as a community. And it doesn't work well if it's just government either. I think the trusted source has to come from someplace else. If you ask consumers who they trust for this kind of information, it's not their insurance company, it's not government, it's their doctor. And so Harold had asked me, he said, would you put up a list to make sure people knew in the audience that we actually get these measures, do this with a bunch of physicians in the room. So picture, if you will, I didn't follow the instructions, but every one of our committees has many physicians from the community that are buying into this, and that's something that we bring as far as the credibility. But it's also very important that we have other stakeholders sitting in the room to be able to develop these measures. One of my favorite is a retired English teacher who really doesn't have much clinical knowledge on this work, but every once in a while speaks up and says, when there's lots of whining about something, says, you sound just like my students when I said, and that actually gets people to sort of refocus about what they need to do. So I highly recommend retired English teachers if you need consumers on your groups. And finally, the key for us has been having actually users in the room to work with this. There's been, one of my favorite times has been when in a group, somebody will come up with a better technical way to do the measure. We really need to fix this because there's a better way to do the measure. And one of the potential users for this would raise their hand and say, you know, that's just not worth the trouble to collect the data because I'm not really going to use that difference to improve the care. And when that's the discussion, that's what you really want to see. And again, that's what a collaborative can bring, that sort of combination of information. We also obviously need to have, we'll hear more about honest brokering. This focus on improvement is so critical. It's not about putting out hundreds of thousands of measures. It's about picking those that are going to make a difference in our community. And this alignment across payers has been so critical. So that comes to my last point that I have for this. Which is the work that we've been doing with our state that I think is a potential across the country to really support the health reform that's going on in states. Because often when we talk about all of healthcare is local, the interpretation becomes, well, we could just do this at a state level. And I think there is something to be said with states have a role in this work, but it needs to be done with a collaborative where we can bring together all the things you've heard about with multi-stakeholders. But we have been very fortunate to be able to work closely with our Medicaid agency as in several ways. One is the state is a major purchaser, both for public programs but also for state employees. So our data has been used for state employees for a number of years in their choices. We've also used it within the Medicaid programs. And again, I think what the value there that's been for those agencies, while they're big enough to do their own measures and have special needs in their populations, especially as state employees have special needs. I was one before, so I can say that. But in the measures, they're big enough. They could run their own data. In fact, they did in the initial years. But what we found is if they work across the community, they get much more buy-in from the providers about making changes. And I want to show you an example of how that can also be to their benefit in just a moment. Also market reform. So as our state is in others, we're working on what we call healthcare homes, others we're working on medical homes, and also accountable care contracting, especially within public programs. So being able to take community-wide measures and adapt them into that environment, both for us being able to develop some new measures in our community that will be meaningful in those contracts, but also bringing standardized measures across multiple payers has been able to get much more effort going on there. And finally, wonderful opportunity with the health insurance exchanges. Now, I think it's going to be a big challenge for everybody just to get these up and operating in the short term. But if all we do with insurance exchanges is give people information about choosing a health plan, I think we failed. The opportunity here that we've been able to demonstrate, even within state employees in Minnesota, is if you give some choices around value of care that goes down to a provider system level and not just the insurance agency, you're able to drive change and get people to focus, consumers to focus on improvement. And so that's our opportunity. We're working with the state around how can we use the data we already have, both in cost and quality, to drive that insurance exchange choices for the consumers better in the future. But I wanted to show this as an example about why it's so important to work together. The state actually has been working with us for public programs on disparity report. Disparities on race and ethnicity is very important in public programs in our state. And this is a chart that's shown over the years for colorectal cancer screening, which you saw before, improvements that have been going on. You can see in the bar for the commercial, but first year we did this great gap for the public programs about their screening rates. And you know, if you just put out data on disparities, what the community can say is, isn't it a shame? Boy, it's really hard to work with those people. What else can you do? Everybody has lower results. It's only when we put this data out and could show by medical group that there were differences in the ability to achieve this that we got a lot more action. And another factor that I think has been very important, many of our groups who are working hard to improve their rates for the total population realized where the gap was in their disparities. They'd done what they could for the commercial population, and the real opportunity was to work on disparities. And so we've seen a major improvement, a reduction in those disparities, even as the overall total has grown in the state. And some of that has been through groups realizing they needed to offer things differently to public programs. In fact, this is only up to 2011 and 2012. We're going to see a much greater jump here from the preliminary data I've seen because of the offering of fit testing for disparity populations. That wasn't done before. Most of the state was working on getting people colonoscopies. So again, just in summary, I think it's very important as we, sort of what can we do to help make this work as Medicare, Medicaid, and the insurance changes are moving forward. Use our trusted source of information, try to build upon that, focus on driving improvement, not just generating lots of measures, and work with communities around the things that really make a difference there. And support that alignment across payers, because if we're not able to do that, we found it just distracts the work, and there's an opportunity for us to be able to align across payers. So thank you very much.